Well, I'm very honored to have these three eminent chairpersons, eminent females in thalassemia who are sharing the session which I'm going to present in. I'm going to talk about, this is Novartis Symposia, update in thalassemia and iron chelation therapy. This is the outline of my talk, general overview, iron overload detection and monitoring, iron chelation therapy, and the conclusion. ليه دي كده فوق؟ أنا عايزة أنزلها. مخبيين مخبيين الهيدنج. انتوا خلاص مش عايزه انيميشن كمان ماشي اوكي. Beta-Thalassemia are actually a group of inherited hemoglobin disorders that result in ineffective erythropoiesis and chronic anemia. And this, what you see, the map containing those are affected by thalassemia, and you see that Egypt is one of the areas where thalassemia is very common. What about the pathophysiology of beta-thalassemia? Actually, there is reduction the levels of beta-globin chain. Either it is complete reduction or absence or decrease in the beta-globin chain. If there is reduced level of beta-globin chain, then there is excess free alpha globin chain, leading to membrane damage to peripheral erythrocytes, leading to hemolysis, and the end result is anemia. On the other hand, if we have absence of the beta globin chain, which is beta 0, precipitation in erythroid precursor within the bone marrow, leading to premature death of erythroid precursors, reduced erythropoiesis, and again anemia. Whether deficient or absent, the end result is anemia. The management of thalassemia, actually the cornerstone of treatment is red cell transfusion and iron chelation. And this is showing you the transfusion therapy, which can result in iron overload, as one blood unit contains 200 milligram of iron plus the iron which will be absorbed. The rate of iron loading influenced the therapeutic goal. Non-transferrin bound iron. Under normal condition, only 30% of transferrin are saturated. In cases of multi-transfusion, as in cases of thalassemia, it will be fully saturated, and more out and free subsequent formation of non-transfusion bound iron in the plasma, which can go to different important organs in the body: pituitary, parathyroid, heart, liver, pancreas, gonads, and cause pathogenesis of these organs due to iron penetration. Iron overload pathophysiology. Iron overload is a consequence of regular RBC transfusion. In the absence of iron chelation therapy, patients receiving regular RBCs will suffer from iron overload. Consequences of iron overload is hypogonadotrophic hypogonadism, hypothyroidism, hypopara, cardiac affection and with heart failure, cirrhosis, diabetes due to affection of the pancreas, and hypogonadism. Iron overload is a consequence of regular RBCs. In the absence of iron chelation therapy, again, there is iron overload. Measure of iron overload, liver iron concentration, LIC, is really very important. In the liver is the primary site of iron storage. About more than 70% of body iron. The iron concentration correlates with total body iron and commonly measured usually by the MRI, but repeated as dry weight milligram per kilogram. This can give you an actual presence of iron inside the liver. A direct measure of body iron stores and is the most, IC, and is the most reliable indicator of body iron load, can be measured on a liver biopsy, which is invasive, which also provides a histological assessment of liver damage, or non-invasively by MRI correlation with dry weight. LIC, or liver iron concentration, is relatively expensive and cannot be used for repeated measurements, especially in poor countries and in unavailable areas like in areas in Egypt. ممكن تبطلي الانيميشن؟ لا مش okay. Iron overload is a consequence of regular RBCs, as we said. Liver iron concentration, the level of iron concentration, liver iron concentration, can give you the amount of damage which can occur. If it is more than 7 milligram per gram, there is increased risk of morbidity and liver disease. More than 15 milligram per gram dry iron, increased risk of hepatic fibrosis, cirrhosis, and malignancy as well. Cardiac effect, increased risk of cardiac disease for liver iron concentration from 7 to 15 milligram per gram dry weight. And more liver iron concentration, more than 15 milligram per gram, there's increased risk of hepatic fibrosis, cirrhosis, and cancer. Increased risk of cardiac disease in this high level of liver iron concentration, which on 50% within 13 years, there is a severe affection of the heart. To start less than 20 milliseconds for the heart, giving you an increased risk of cardiac arrhythmia, but it is less than 10 milliseconds, the increased risk of heart failure and death. So to star measurement for the heart is very important to give you a prognostic effect of iron overload on the heart and on the patient. At the molecular level, reaction oxygen species concentration in hepatocytes increases with liver iron concentration. This is showing you low concentration of reactive oxygen species and high with complete destruction of the liver cells. Iron overload and reactive oxygen species stress result in mitochondrial damage. The introduction of transfusion improved survival in transfusion-dependent patients. Left untreated patients should die within a few years of birth. And you should see that when there is blood transfusion, the mortality of the patient remarkably decreased. The introduction of iron chelation therapy as well improved survival in transfusion-dependent thalassemia. The chelation and iron chelation are very important for the prevention of complication and lifespan of these patients. Probability of survival to at least 25 years of age in poorly chelated patients was just 1/3 that of patients whose iron levels were well managed. Transfusion iron overload leads to multi-organ morbidity in transfusion-dependent thalassemia. In the pituitary with hypogonadotrophic hypogonadism, in the heart, in the gonads with hypogonadotrophic hypogonadism, in the bone with osteomalacia and osteoporosis, as well in the cardiac and in the endocrine, in the thyroid, hypothyroidism and hypoparathyroidism, and as we already know that liver, it can cause liver cirrhosis and cancer. And in the pancreas, all of us know that iron overload can cause diabetes in not well-chelated patients with thalassemia. Iron loading in different organs in transfusion-dependent thalassemia can occur at different rates. Heart and endocrine glands usually lag behind liver. liver is first. Increased iron absorption and release, leading to reticuloendothelial system, leading to high serum iron, increased transferrin saturation, leading to the formation of non-transfusion bound iron in the plasma, leading to hepatocellular iron overload. Excess iron overwhelms hepatocytes' capacity, leading to liver damage, and this can give iron leakage, low transferrin production, and low hepcidin production. Reduced non-transferrin bound iron clearance, leading to systemic iron overload and the affection of more different important organs of the body. Iron overload occurs in the absence of transfusion in non-transfusion dependent thalassemia. Ineffective erythropoiesis, chronic anemia and hypoxia, the enzymes or the factors which can act on hepcidin, decreasing hepcidin, this will lead to increased release of recycling iron from the reticuloendothelial system, and on the other hand will decrease ferroportin. This will increase intestinal iron absorption and iron overload. Iron overload in non-transfusion dependent thalassemia is actually associated with multiple extrahepatic manifestations. It can lead to pulmonary hypertension and venous thrombosis, can lead to silent cerebral infarcts by MRI, large vessel stenosis, decreased neuronal function, as well endocrinopathy and osteoporosis, proteinuria, affection of the kidney, and end-stage renal disease. And actually now we see renal affection with thalassemia. Professor Tahir has got a lot of study in this domain, and as well other affection of other organs, solid and hematological malignancies. Iron overload assessment and decision making. In blood, serum ferritin. Serum ferritin for iron overload measurement in transfusion dependent thalassemia and non-transfusion dependent thalassemia. Actually, in transfusion dependent thalassemia, good but not always perfect correlation with liver iron concentration. There's poor correlation with cardiac iron. On the other hand, in non-transfusion dependent thalassemia, it may underestimate iron burden if not interpreted correctly. It may give good, low, but this is not give a correlation with the actual effect of iron overload on different organs. Serum ferritin in non-transfusion dependent iron, serum ferritin more than 800 microgram per liter identified as a threshold for higher incidence of morbidities in non-transfusion dependent thalassemia. Iron overload and decision making for the liver. Liver iron concentration thresholds are linked to clinical morbidity and mortality in transfusion dependent thalassemia. Liver iron concentration can be measured by either liver biopsy, by SCID, or by MRI, R2 or 2 star. Liver iron concentration more than 7 milligram per gram dry weight, there's increased risk of morbidity and liver disease. Increased risk of cardiac disease for liver iron concentration from 7 to 15 milligram per gram dry weight, 28.6% within 13 years. But if it is more than 15 milligram per gram dry weight, there's increased aminotransferase enzyme concentration or increase in the liver function, increased risk of hepatic fibrosis, increased risk of carcinoma of the liver, secondary cirrhosis, and increased risk of cardiac disease as well. So liver iron concentration is very important for the morbidity of patients with thalassemia to determine. Iron overload assessment decision for the heart. Low myocardial 2 star predicts a high likelihood of cardiac failure and arrhythmia. cardiac failure. If it is below 6 milliseconds, this is very hard and very ominous sign for the lifelong of the patients. Arrhythmia, if it is less than 10 milliseconds, this is need follow-up for the patient, and this is another cause of arrhythmia in these patients suffering from thalassemia. Iron chelation therapy recommendation in transfusion-dependent thalassemia, TIF guidelines, which is really important and should follow the start after 10 to 20 transfusions or liver iron concentration more than 7 milligram iron per gram dry weight. If liver iron concentration is not available, then we can look to serum ferritin. If it is more than 1000 nanogram per milliliter, I have to start. To monitor iron overload, iron level, serum ferritin, liver iron concentration, and myocardial iron concentration. Chelator toxicity, we can look for ear and eye health. Renal function, we have to look for serum creatinine, neutrophil level, symptoms of infection, for example, the presence of fever, and liver function, we have to look to liver function, AST and ALT. To adjust, iron level increasing or too high, increase chelator dose or frequency, switch, if it is, we can switch the chelator, rotate or combine chelators, assess and address adherence. And this is very important because many times the patient is not adhering well to the iron chelation therapy. And this is one of the disadvantages of using an iron chelator which the patient does not like. Iron level at low level, consider decreasing chelator dose. And chelator toxicity, should observe chelator toxicity and consider decreasing chelator dose if there is evidence of toxicity. For iron chelation therapy, without adequate chelation, iron overload leads to organ failure and mortality in beta-thalassemia. Assessment and monitoring of iron overload is an essential component of effective iron chelation therapy. Serial magnetic resonance imaging studies have established the temporal sequence of organ loading during transfusion, where liver loading is followed by pancreas loading and lastly cardiac loading. Serial monitoring of tissue iron during chelation treatment revealed that the rate of unloading is not the same in all tissues. The time to remove half the iron from the liver is 4 to 6 months. The time to remove half the iron from the heart is 17 months. The three most common tests is serum ferritin, liver iron concentration, and myocardial iron estimation. So the use of MRI in our patient is very important, because I'm observing that we are not commonly here in Egypt use MRI for detection of liver iron overload and cardiac overload, and always depending only on serum ferritin, which is actually not the proper idea, a proper way to keep your patient in a good health. Progress in iron chelators, iron overload monitoring in the management of thalassemia. You know that the cornerstones of treatment are red cell transfusion and iron chelation. The role iron chelators improved the compliance to chelation therapy, improvement quality of life and survival. Cardiac magnetic resonance imaging, this is very important actually, and this is by moving and knowing the amount of the cardiac iron overload is very important to keep the patient in a good health and to keep the survival of the patient. And in this journal, there is improved survival of thalassemia major in the United Kingdom and relation to T2-star cardiovascular magnetic resonance, giving you a clue that follow-up by magnetic resonance for these patients can give you a clue the patient is good or not, is going to live well or not. There's advances of oral inoculators and of monitoring, and we have got many. Before that, can serum ferritin, liver iron concentration, and so on. The introduction of oral inoculation as well, before there was this Feral, which is very boring for the patient, very boring to take an injection over 8 hours intravenous or over 24 hours subcutaneous. So, introduction of oral inoculation therapy was associated with improved patient satisfaction and health-related quality of life. Willingness to take inoculation therapy, preference, time gained, and quality of life remarkably improved. So oral inoculation have got a good outcome for the life and outcome of the disease of thalassemia. We have Deferozirax film-coated tablets. 2 new formulations of Deferozirax are being developed. Film-coated tablets and granules, primarily to address palatability issues associated with the currently approved dispersible tablets. There was first Gen XJ, which is dispersible in a big amount of water, and the patient take in the early morning before taking his breakfast, which was very boring for many of the patients. Jadnu, has been thought to help aid in reducing potential dosing errors because it will take it by less dose between different formulations of Deferozirax, each with its own distinct dosing and administration. Deferozirax film-coated tablets received FDA approval in 2015, long ago, 7 years ago, and EMA approved 2016. This is showing you the inoculator therapy starting from this Feral going up to Jadnu. The development of Deferozirax film-coated tablets, Deferozirax dispersible tablets, and showing on the other side the Deferozirax film-coated tablets. Film-coated tablets have a greater bioavailability compared with dispersible tablets, which is one of the advantage. Dispersible tablets versus film-coated tablets, starting dose is 10 milligram. Film-coated tablets is 7. Titrating increments is by 5 to 10 in the dispersible, and it is 3.5 to 7 in film-coated tablets. Maximum dose is 40 in this one dispersible and only 28 in film-coated tablets. It is 30% less than the dispersible tablets. Film-coated tablets safety data are within the known safety profile for the dispersible tablets. Oval biconvex film-coated tablet with beveled edges deposed on one, this sign NVR on one side and those on the other side. There is 90 milligram tablets, 180 milligram tablets, and 360 milligram tablets, as you see, and every one with different color, with different intensity of the yellow color. The mean domain score for patient respond outcome showing that there's marked improvement in the patient response outcome towards the new one than the XJ, the other one. Improved efficacy of Deferozirax film-coated tablets might be mediated by better adherence and perception of treatment. Adherence coming out from the patients, assigned treatment both together, and on the other side, absolute serum ferritin reduction from baseline. Adherence is very important. Satisfaction concerns and palatability towards the film-coated tablets. So, the conclusion, iron overload is associated with a significant risk of morbidity in both patients, non-transfusion dependent and transfusion dependent patients, with effects on various vital organs. Advances in detection and monitoring of iron overload by MRI now allow the assessment of specific organ loading rates to help tailor iron chelation therapy. Available iron chelators have shown efficacy in removing iron from the liver, heart, and endocrine glands at various levels of iron overload severity. Advances in iron overload management include the introduction of a new Deferzorax formulation aimed at improving adherence. Many novel therapeutic agents targeting iron dysregulation are also currently in clinical trials. Survival and the quality of life of thalassemia patients remarkably improved after the era of oral iron chelators, and the non-invasive facilities, cardiac MRI, T2 star, and R2 to monitor cardiac and hepatic iron load. Several targets have been identified that can ameliorate a genetic defect, ineffective erythropoiesis, or iron dysregulation. As you already heard on, luspatercept decreases this erythropoiesis, and gene therapy, gene editing, all this ameliorate and will by and by ameliorate the disease and will be widespread among patients because it is very limited and limited in limited areas of the world. And this is to thank you for your kind attention.